Hi, Dr. Robin Trotman, infectious disease physician at CoxHealth here in Springfield. Today's December 22nd. It's been a while since we've talked. We're going to do an update on the current COVID pandemic situation, talk about Omicron, talk about vaccines and some of the new treatments. So keep in mind the current situation is what it is on December 22nd. This is rapidly evolving. This is dynamic. So when I tell you today that the Omicron variant hasn't been identified in Southwest Missouri, that may change tomorrow. What we're really finding out now is that there's a few characteristics of the disease from Omicron that might be a little different. This virus might actually result in symptoms faster than the Delta virus. So let's say you got infected on Monday, somebody coughs on you Monday, you might actually get sick Wednesday or Thursday. If you think way back 2 years ago, we told everybody the incubation period is 5 to 6 days. So the incubation period of this Omicron virus is likely to be a little bit shorter. That's one unique characteristic. We go into this winter, we go into the cough cold season. We've got the Omicron wave coming. It sounds gloom and doom. If you work here at Cox, if you work with me, we have a question, we have an opportunity to keep our patients safe, to keep our work staff safe, to keep our employees here so we can take care of our community. So if you haven't received your booster vaccine, I don't know how many people have asked me, should I get this booster? Again, 2 months ago, I said you might want to wait. It's a different calculus now. If you're waiting on your booster, you need to get it if you're eligible. So if you've had those first 2 vaccines and you're eligible for the booster, you need to go get it. That's what's going to keep our operations running here. The notion of natural immunity it's not going to protect you in this wave. It might be additive with the vaccine. So if you do have natural immunity and you get a vaccine, you're going to be much, much better off than without the vaccine. So we really need people, we need our staff here, we need all hands on deck, and we need everybody to seek out that booster now. Initially, it was a soft recommendation, it's available. Let me tell you, it's safe. We're giving doses of this booster and we're not seeing serious side effects. You know, your arm hurts, my arm was pretty sore for a while. 24 hours, I felt better. And I have more confidence walking into rooms with patients with COVID or walking into rooms with patients who I don't know if they have COVID. So that's the current situation. It's changed in the last 2 months and it may change again, but I can't implore our work staff enough. This is going to be key to keep our operations up and running through this next wave. So think about your own health, think about your patients and your family, and seek out that booster when you're eligible. We have some new developments in treatments. First, I'm going to start with the pill. Everybody's heard about the Molnupiravir. That's the oral antiviral that was touted early. So if you look at the data supporting this, what's the goal of this pill? Well, the goal of this pill is not to keep you from getting infected. It's to keep you out of the hospital and from dying. And the data look pretty good. It's not as hopeful as it was initially presented, to where it was maybe 85% reduction in hospitalization. It's probably down on the order of 20%. And this pill is not a substitute for vaccination. So here's the deal. The one thing that I have certainty in is that 3 doses of mRNA vaccine today will keep a immunocompetent, meaning a normal immune system person, out of the hospital. The Molnupiravir, by the time you get that medicine, it's too late. We're not going to have a large stockpile of that drug. This drug is coming from the federal government to the state, and then it's being distributed to different healthcare systems, and there's not going to be a surplus of it. It's going to be relegated to people who have a high risk for being hospitalized when they're infected. So this pill, while it looks hopeful, it's not going to be the solution. The solution is going to be that booster vaccine to get us through this next wave. Some of the other treatments, the monoclonal antibodies, it appears that some of these drugs like bamlanivimab you've heard of, or the Regeneron, probably not very effective against the Omicron variant. Now, keep in mind, those are test tube experiments. We won't know if it's effective until we've treated large volumes of patients. So we have to treat a lot of people and see how many of them end up being in the hospital. And then we'll have outcome data. Very important to separate outcome data of a drug versus what it does in a petri dish. And so it appears that in the petri dish, those 2 drugs, bamlanivimab and Regeneron, they don't neutralize this virus as well as we had hoped. There's a new one on the block, sotrovimab, That's GSK's drug. That one does appear to have good neutralizing properties. Unfortunately, it's not widely available right now, and it's just being rolled out through the federal government's program. So stay tuned. There'll be more information on that. We've placed orders. We're trying to procure this drug, but it's scarce, just like a lot of our other COVID resources. And then the last treatment that we have is going to be a monoclonal antibody called Evusheld, and you may have seen this in the news. That's going to be a pre-exposure treatment, meaning we're going to take our patients who are unlikely to respond to a vaccine because they have immunodeficiencies. Maybe they have leukemia, they're on chemotherapy, or maybe they have low antibody levels at baseline. So those people would not respond well to the vaccine. We can give them a dose of the medicine called Evusheld, and hopefully that will protect them for several months, maybe up to 6 months. Now, how that protects them against Omicron, it's too early to tell. It's probably not as effective in the Petri dish, meaning in vitro, but we're really going to need outcome data. We're going to need clinical evidence to inform how we use that drug. So the last thing, this is the bad news. If you do get infected, if you do have those symptoms of COVID, runny nose, sore throat, cough, fever, muscle aches, loss of smell, taste, if you have those symptoms, even though we have the cough and cold system, you need to be tested. One of the keys to get us through this next wave is going to be early identification of people who have this infection, because if the transmission rate is higher and if the incubation period is shorter, early testing is going to be key. Something else we've learned is that the efficacy of the monoclonal antibodies, so if you go in and get your Regeneron, if you wait till after 6 days from onset of symptoms, the efficacy, the ability to prevent severe disease or hospitalization drops by 50%. So that drug is more effective if given in the first 3 days of symptoms than it is at day 8. So there are multiple reasons to be tested, right? If you test positive, you can stop the transmission right there. We don't want people coming to work sick. We have testing available for employees. So early testing, if you have any of those symptoms, is going to be key. And keep in mind the incubation period's 3 days, so maybe as short as 3 days. So if you know you've had a significant exposure, someone at home, then that's where we're going to look towards quarantine and testing of employees before you return or as you return back to work. We're going to keep our mitigation strategies up. We're going to keep our masks. We're going to try to limit the amount of people in rooms and gatherings. But again, testing is key, and you need to seek that out if you do develop symptoms or if you know you've had a significant exposure. Not only to get you out of the workplace if you're going to be sick or prevent transmission to family, but also if you're eligible for some of the monoclonal therapies. They work better early. So as of December 22nd, we still have 50 million Americans who are unvaccinated. We have a high population here in Southwest Missouri, and that's who I'm seeing in the hospital now is almost solely unvaccinated patients, and it's sad. These are our family, our friends, our neighbors, and I think as employees here at Cox, we're all healthcare workers in some way. We all have a duty to try to help these people understand, to meet them where they are, to listen to their concerns about the vaccine. Most of the people who are still hesitant about being vaccinated have very good explanations, and they want what's best for themselves and their family. They don't want to be sick. And so that conversation usually entails the healthcare worker just zip your mouth for a few minutes and listen to what they have to say and try to meet them there. And often they just haven't been listened to or haven't had a doctor or haven't had anybody specifically ask them if they're vaccinated. So I think we all need to fly that flag of the vaccine going forward. It's what's going to get us through the holidays. I hope everybody can stay safe, and maybe we'll have an update towards the end of January.